A warm greetings to all. We are here for TANUVAS Global Veterinary Large Animal Sciences Webinar Series 2, 2021. May I request Dr. R. Ezekiel Napoleon, Professor Head, Department of Clinics, Veterinary College and Research Institute, Namakkal, for the welcome address. A warm greetings. Napoleon.
Thank you. Good evening and welcome to the TANUVAS Global Webinar Series organized on the large animal clinical sciences. I, on behalf of the organizing committee, extend a heartiest welcome to our Honorable and beloved Vice Chancellor of TANUVAS, Dr. C. Balachandran sir. Despite his busy schedule, being present and he is here to grace the occasion. Welcome you, sir. I would like to extend a warm welcome to our beloved Registrar of TANUVAS for having granted permission to organize this webinar today and tomorrow. TANUVAS being the first veterinary university among the Southeast Asia, the first veterinary university in India, the first veterinary university to organize various global webinars and intercollegiate web-linked seminars in our... Likewise, this global webinar on large animal sciences is going to be the first of its kind in the 2021 under the Directorate of Clinics, TANUVAS. I would like to welcome the icon of this global webinar and the hypothalamic stimuli in organizing this event, who is none other than our Director of Clinics, TANUVAS, Dr. S. Balasubramanian sir, who was instrumental in interlinking all the constituent colleges of our university in the event of exposing all the clinical activities between Madras Veterinary College, Veterinary College Research Institute Namakkal, Varathanad and Tirunelveli in topics like ultrasound scanning, dermatology, clinical, critical care, stethoscopy, etc. Even the first ever webinar was organized well in the year 2014, first for the TANUVAS, by the then director of the summer school, sponsored by ICR, who was also Dr. S. Balasubramanian sir. So, I'm very happy to welcome Dr. S. Balasubramanian sir, who is also instrumental for this program, which is going to be the 8th global webinar series for our TANUVAS. Welcome, sir. I would like to extend a warm welcome to all the deans of the constituent colleges of TANUVAS, all university officers, faculty, staff members, students awaiting for active participation. On behalf of the organizing committee, I extend my warm greetings and welcome to the international speakers. First is Dr. Elizabeth CARR, Associate Chair, Large Animal Clinical Sciences, Michigan State University, USA, an equine specialist, and Dr. Brandon Fraser, Queensland University, Australia, a specialist in small ruminants, and Dr. Angel Abilo, Large Animal Clinicians, Michigan State University, who is going to talk about production disease of cattle, who have consented with the great spirit of interest in caring, bearing, and sharing of the scientific knowledge for the society around the globe. I extend my warm welcome to the Vice President of Alembic, Mr. Karnanidhi, and Dr. Santosh Shinde, AGM, for the courtesy, and Dr. M. Tirunakar sir and his team for the web facilities provided. As part of the organizing committee, I welcome all the co-organizers, technical coordinators, and moderators of this global webinar series for a grand success. Thank you very much for this opportunity. Thank you.
Thank you, sir. Now may I request respectful and beloved Director of Clinics, Tamil Nadu Veterinary Animal Sciences University, Professor Dr. S. Balasubramanian, for the introduction of the webinar.
Most respected and Honorable Vice Chancellor, Tamil Nadu Veterinary and Animal Sciences University, Professor Dr. C. Balachandran. Speaker of today's webinar, Dr. Elizabeth CARR, Associate Professor, Associate Chair, Large Animal Clinical Sciences, College of Veterinary Medicine, Michigan State University, USA. The Organizing Secretary, Dr. Napoleon, Professor at Department of Clinics, VCRA Namakkal. The co-organizing secretaries, Dr. Vijay Kumar, Dr. Sendil Kumar, and Dr. Shankar, The technical coordinators, Dr. Tirunavakarasu, Dr. Vimal Rajkumar, Deans of Constituent Veterinary Colleges, Dr. L. Nagarajan, Professor Head, Department of Clinics, Dr. Krishna Kumar, Head of Department of Veterinary Gynecology and Obstetrics, Dr. Arun Prasad, Head of RVSS, Thiru Karunanidhi, Vice President, Alembic Pharmaceuticals, heads of the department, faculty members, participants from India and overseas countries. Greetings and good morning and good evening to one and all. Though it is belated, on behalf of the Directorate of Clinics TANUVAS, wish you all a very happy, healthy and prosperous New Year 2021. At the outset, I would like to thank the Honorable Vice Chancellor TANUVAS, Professor Dr. C. Balachandran, for his directions and munificent support for all the webinars organized by this Directorate till today. The Directorate of TANUVAS has so far organized 4 webinars for students with the constituent veterinary colleges of TANUVAS, 7 global webinars for the benefit of students, faculty, field and practicing veterinarians worldwide. And this is the first global webinar, as said, for this year 2021, and it is 8th in the series. The Department of Clinics, Veterinary College and Research Institute, Namakkal, functioning under the control of the Directorate of Clinics, is now organizing this Global Veterinary Large Animal Sciences Webinar Series 2, 2021, on critical care and medical management of diseases in foals, medical management of diseases of small ruminants, and production diseases in cattle. So just to give a brief intro about this global webinar, as you all know that abnormal or weak newborn calf, regardless of the cause of its problem, had no potential to develop into a useful adult. The management of critically ill equine neonates is extremely challenging, but there have been tremendous advancements in the care of these foals over the past several decades. When assessing an equine neonate, it is important to remember that the first few minutes and hours after birth are a profound adaptive period, and that the normal parameters used in the assessment are continually changing during this time. All of the foal's body system are transitioning from the protected intrauterine environment, in which many of their functions were primarily performed by the mare via the placenta, to the external environment, in which these systems assume full responsibility for maintaining homeostasis. The time required for this transition varies by body system, and the adaptations required for the cardiopulmonary system are the most critical. There are a number of endocrine changes occurring in the periparturient period, and these changes are critical in preparing a number of body systems such as lungs, gastrointestinal tract, kidneys, and liver, for the functions they'll be responsible for following birth. An update in the management of diseases of foals and critical care will help to provide more information to UG, PG practitioners to treat and tackle these conditions under field conditions. Coming to the production diseases, which is going to take place in the next day, that is tomorrow, the production diseases of dairy cow are caused by a level of production inconsistent with nutrient intake, provision of an inadequate diet, an unsuitable environment, an inappropriate breeding policy, or various combinations of these factors. Although the transition period of 3 weeks pre-calving until 3 weeks post-calving is associated with the peak incidence of production disease, the effects of these diseases on dairy cow health and productivity extend far into the following lactation. So recent advances in understanding of production diseases include the emergence of propylene glycol and rumen-protected choline as the supplements of choice for preventing fatty liver, and the absence of any penetrative effect of increased energy density in the close-up dry period diet on this condition. The linear negative influence on dietary action, cation-anion difference, that is DCAD, on the incidence of milk fever, regardless of urinary pH or target level of dietary DCAD achieved. the inflammatory response associated with subacute rumen acidosis and its effect on feed intake, and increased awareness of the potential for antioxidant status to improve immunity and health in the transition period, the development of more standardized diagnostic criteria and treatment protocols for uterine infection. Likewise, the last speaker would be giving a talk related to sheep and goats, which will contribute greatly to the country economy, especially in the areas where crop and dairy farming are not economical and play an important role in the livelihood of large proportion of small and marginal farmers and landless laborers. Ectoparasites, endoparasites, malnutrition, and infectious diseases are of major concern in small ruminants, causing mortality, morbidity, and reducing the productivity. I congratulate the entire team behind this event and extend my heartiest wishes and thanks to Dr. Elizabeth CARR from USA for readily accepting our invitation. I am confident that the information gained in this two-day global webinar will be very useful in strengthening the knowledge and its application in day-to-day practice. Thank you.
Thank you very much, sir, for the brief introduction on the webinar. Now, on behalf of the organizing committee, may I request Honorable and respected Vice Chancellor, Tamil Nadu Veterinary Animal Sciences University, Professor Dr. C. Balachandran, for the inaugural address.
Very good evening from Chennai and greetings from Tamil Nadu Veterinary and Animal Sciences University. Our honored guest speaker, Dr. Elizabeth Khan, respected Director of Clinics, Dr. Balasubramaniam, and heads of departments, Dr. Ezekiel Napoleon, Dr. Nagarajan, Dr. Krishna Kumar, Dr. Arun Prasad, Dr. Vijay Kumar, and students, dignitaries, and my dear participants. I'm quite happy to be here on the 8th webinar that is organized by the Directorate of Clinics of this university for the benefit of students, academicians, and practitioners. So just in the COVID-19 pandemic, this is another option that has been given and well effectively used. And several topics have been dealt through these 7 webinars, namely on the imaging, anesthesia, critical care, clinical pathology, and management of disease of cattle and horses. So that are addressed by the renowned international speakers from USA, Canada, West Indies, Poland, and UK. And I'm happy that they have started in the first week of this new year 2021. And the first speaker will be Dr. Elizabeth Carr, delivering on the critical care and medical management disease of foal, and followed by Dr. Brandon Fraser and Dr. Angel Abilo, talking on medical management of disease in small ruminants and production disease of cattle tomorrow. So the doctor has given overview about the issues related to these topics, and of course the neonatal condition that is changing rapidly compared to adult horses. You have high risk or sick neonate foals that is requiring frequent observation, detection of new problems, and then solve those things. So I'm given to understand that around 5 to 7% of newborn foals have some significant health issues and need intensive care to survive. So these problems can be solved and from the advances made in the care of human infants. So like human infants, foals differ physiologically from their adult counterparts and they require specialized treatment based on an understanding of their unique physiology. So much has been said about whatever several transitions that are going in them, including complex behavioral, metabolic, or cardiopulmonary, endocrine, hematologic, and other systems. The conditions of sepsis, diarrhea, hypoxic injury, colic, prematurity, respiratory distress can cause serious problem in foals and can lead to mortality. So an update in critical care and medical management disease in foals by specialist in equine medicine, that is Dr. Elizabeth CARR, will help all our students and practitioners to face these challenges. Coming to the other aspect, that is high-producing farm animals are permanently challenged by a variety of factors, including lack of proper nutrition, deficit or surplus, housing systems, infections, and stress. So the incidence, course, and outcome of these production diseases are changing continuously, naturally, as changes occur. And therefore, new information on prevention, diagnosis, and treatment of production diseases are required. And on the sheep and goats, which are contributing significantly to the Indian economy by sustaining livelihood and supplementing the income of farmers and rural poor through sale of various products and the byproducts. The incidence of diseases and parasitic infections and infestations is one of the major constraints in the development of small ruminant enterprise, contributing towards substantial losses to keepers. So diseases in goats result in mortality, which ranges from 5 to 25% in adults and 10 to 40% in kids. So probably these deliberations by international speakers on the topics critical care of foals, production disease of cattle, and management of disease of small ruminants will definitely benefit our undergraduate, postgraduate students and the practitioners and acquire important technical and field-oriented skills. So that way it is a good thing. I just congratulate the organizing team and wish them a good luck for the successful conduct of the webinar, and thank the organizing committee for giving me an opportunity to talk to you. Thank you, friends.
Thank you very much, sir, for the inaugural address. Now, I have a great privilege and pleasure in introducing Dr. Elizabeth CARR. She had a Bachelor of Science Biology in 1982 from Cornell University. In 1985, she had a graduate work in infectious disease and microbiology at Harvard School of Public Health, Cambridge. She obtained the Doctorate of Veterinary Medicine at Tufts University School of Veterinary Medicine. In 1989, at Washington State University, she had her graduate studies in veterinary science. In 2000, she acquired Ph.D. in comparative pathology from University of California, Davis. And she had to her, this one, she is a diplomate in American College of Veterinary Internal Medicine. She's a diplomate American College of Veterinary Emergency and Critical Care. And she also had certified veterinary acupuncturist from International Veterinary Acupuncture Association. In 1999, she became assistant professor, large animal clinical sciences, School of Veterinary Medicine, Michigan State University. And now she is chairing, associate chair and assistant hospital director, large animal clinical program, large animal clinical sciences, College of Veterinary Medicine, Michigan State University. Now over to Dr. Elizabeth CARR for the lecture on critical care and medical management in foals.
Thank you for inviting me to speak today. I hope that I cover enough that of interest for you guys. There's obviously a lot to neonatal medicine. I think my goals with today's lecture are really to talk about some of the simple things that you can do to really increase the success or outcome with neonates. Really from the perspective of being in a tertiary referral hospital, one of the biggest problems I see in terms of neonatal medicine is the lack of recognition of problems when they first develop. And so by the time the neonate presents to the hospital, they're often quite sick, and the prognosis can be a lot worse, as opposed to if there's a early recognition and awareness of problems as they develop, and then interventions, the outcomes are often much better. So the beginning of this talk, I'm going to talk a little bit about how I teach my students to, when they're evaluating a pregnancy and a mare and a foal, what are the critical things that should alert you or be, let's say, a red flag that should alert you that there may be a problem with this pregnancy or this foal. And then after that, I'm going to talk about some various diseases that you had asked me to discuss. So I have the chat, I have the team open. I do not have the chat open. So if for some reason I lose you, let me know by typing a message in the team. Hopefully I will see that. So the term high-risk foal, or I often call it the red flag foal, so a foal that I am concerned about, that definition I base on classifications looking at various factors in that foal's, the pregnancy, etc. So essentially what I call a high-risk foal would be a foal that warrants either a greater degree of surveillance, care, or intervention. So you may just elect to evaluate this foal more cautiously, or you may elect that this foal needs to be started on some sort of therapy, whether it be putting in a nasogastric tube or even starting them on antimicrobials or fluids. And I divide up the classification of how I decide this foal's a high risk on 4 areas: historical information, information about the actual foaling, how the foal behaves immediately post-foaling, and then farm-associated problems. So let's say we have a farm that has an outbreak of diarrhea on its farm. With respect to historical information, we're going to talk about the mare, the pregnancy, as well as you have to include farm. In other words, if there's illness or disease on the farm. With the mare, again, illness and chronic pain or travel. So we know that illness or pain in the pregnant mare can result in a foal being born early or premature based on dates. We do know, though, that in terms of the types of illness, in general, a mare that has a chronic long-term illness versus a mare that has an acute, let's say, colic a few weeks before she's due to foal, of the two, actually, the chronic illness is a little bit better in terms of the likelihood that that foal will be born normal. And that's because with chronic illness, there's an opportunity for stress hormones to increase and actually cause fetal maturation to speed. And so a mare that, let's say, has a chronic illness, let's say renal insufficiency, or even chronic pain like a laminitis case, that foal is often in a better position when it's born. It may be small because it's been premature, but it's often developed appropriately. So it's premature based on gestation, but actually all of its organ systems may be well developed. It's often smaller than you would expect, but it's actually more likely to be born and be able to thrive versus a foal that's born to a mare that has, let's say, an acute colic episode 2 weeks prior to foaling. Because foals have, it's so critical that they have the complete opportunity to develop in utero. Even a couple of weeks prematurity can sometimes be the difference between survival and death. And so an acute illness where there's not enough time for stress hormones to speed up fetal maturation can result in a premature or dysmature foal that may have multiple problems associated with that dysmaturity. Obviously, twins, we know, are a problem. When twins are born, often one or both of them can have problems and be weak and need assistance. Placentitis is another concern that we have with if mares that have placentitis during gestation. So any signs or symptoms or suspicion of that. Obviously, dystocia is a big one. And then again, farm-associated concerns. So placentitis can a mare can have placentitis and have no clinical signs. So it is a disease that can be hard to determine. The most common signs we would see with placentitis are typically early lactation. And you can see in this picture, there's milk on this mare's legs or secretions. It may not be true milk at this point. Seeing that, any significant amount, particularly if it's before the foaling date, should arise a concern and have you consider evaluating that mare for the possibility of placentitis or some in utero problem that's causing this early lactation. Sometimes you'll see a discharge from the vulva, although this is not particularly common. So in cases where I'm concerned about placentitis, examining the cervix using a speculum carefully, and then possibly doing an ultrasound exam to assess the fetus and the amniotic fluid, etc., as well as the uteroplacental thickness would be warranted. In addition, in this history, it's important to get information from the client. Has the mare ever had twins? Has she ever had sick or weak premature foals? And then obviously, but often missed, clients may not elect to mention this, but has the mare had a foal with previous disease like neonatal isoerythrolysis? We'll talk about that a little bit later, but that's a preventable disease, but will recur if the mare is bred to the same stallion. So gestation length in horses, we know, should be around 320 days to 350 days. We call normal gestation length 341. However, it's important to recognize that horses are a species that they have a huge variation in their foaling dates. And so one mare's foaling date may be weeks different than another. The good news is mares tend to follow the same date. So if you have a mare that's been a brood mare previously, she typically is going to foal about the same date that she did in previous. So knowing if she foaled at 328 days or 340 is critical. We consider a baby that's born before 320 days to be called premature, and that's just based on date. But remember, foals can be born at a normal gestation length and potentially appear premature. In that case, they're called dysmature. The terminology is not nearly as important as the recognition that you have a foal that has signs of prematurity, because as we'll talk about later, changes externally are one thing, but it's the internal prematurity that we worry about and should put this foal into a high-risk category. In addition, if a mare foals early or carries past what is her normal due date, that should be a red flag, and you should make sure that when that foal is born, that you as a veterinarian assess that foal fairly early and monitor that foal at least over the first couple of days, because that foal may potentially have problems that'll arise. Again, obviously, premature foaling stress, so premature placental separation. This picture on the top is what is commonly called a red bag, which is when the entire placenta separates at one time. Normally during foaling, the placenta starts to separate microscopically, so there's detachment, but it's at a microscopic level. As you know, usually the foal is born and the placenta completely separates and passes sometime within the next few hours. When the entire placenta separates rapidly before the foal's even been born, you have complete loss of oxygen delivery to that foal, and that's a medical emergency. We recognize that there can be subclinical premature placental separation that can actually happen during late pregnancy or during the foaling period. And really, it's a continuum. We know this happens during foaling. The question is, how severe is it and how rapidly does it progress? But obviously, if you see a pregnancy, a foaling situation, and you are presented, instead of seeing feet sticking out or under a clear amnion, you're seeing a red or a salmon-colored thick layer, and you cannot see the foal in it, that's a premature placental separation. It's a medical emergency. This should be opened as soon as possible so that the foal can be extracted. And this foal will definitely have problems. It's had severe oxygen deprivation during foaling, unlike normal, in which they have some oxygen deprivation, a normal physiologic occurrence. This is pathologic because it's severe and complete. Similarly, any foal that has a dystocia, even if it's born, you're able to resolve it rapidly, that foal should be a high-risk foal because we assume that they have a much higher loss of oxygen during that delivery period, and they may have secondary complications associated with that oxygen deprivation and ischemia and tissue injury. We'll talk a little bit more about this later. Once the foal is on the ground, post-foaling behavior is important to assess. So as mentioned earlier, it is a very stressful period. They're going from an in utero environment, expanding their lungs. They go through a fairly significant period of hypoxemia and hypercapnia and acidosis. So at birth, a foal should have a respiratory rate somewhere in the 80 to 100. But even at that immediate post-foaling, they have a very strong desire to sit sternal. And they should sit sternal within a few minutes. They should stand on average within 2 hours, and they should nurse within 3 hours. Remember, they are a precocious species. They have to be able to get up quickly and be able to run away with their mom because there are predators out there that would love to eat them for dinner. So they should be able, within a short period, to get up and get around, and over the course of the day, should be able to be fairly active. Normal foal behavior post-foaling, they have a pretty boring life, if you will. They essentially eat, play, and sleep. And within that period of time, they also urinate and defecate. Foals can nurse up to 5 to 8 times an hour. Unlike calves, they tend to nurse for very short periods. So they'll have a little drink, then they might play, urinate, etc. And then generally they sleep again, get up again, etc. One of the most important things to remember, though, and this is a series of pictures of a foal that was in the hospital, is that they should be easily aroused. This idea of a sleepy foal that a client thinks is just sleepy, to me, is something to be concerned about. Yes, they sleep, and yes, sometimes when you go into the stall with them, it might take a second for them to arouse. But most of the time, again, they're prey animals. They should rapidly want to jump up. And this foal, despite the fact that it had been in the hospital, had actually had surgery and been handled multiple times, as soon as I opened the stall door while he was sleeping, he jumped up, ran around behind his mom, and stood alertly waiting to run away from me. That's kind of the behavior you'd like to see. And then once I left the stall, he went over and had a good nurse and carried on with his day. Foals should urinate sometime within the first 12 hours. In the fetal, the fetus is actually volume expanded, and which is good because it means that in that early postnatal period, they have extra fluid resources that they can use should they not be getting adequate fluid therapy. Because they're so volume expanded, they should urinate quickly. And if you remember, and we'll discuss this a little bit later, they have a fairly high water intake. Neonates at birth drink about 15% of their body weight in milk a day, up to 20 to 25%. So if you have a 50-kilo foal and it's drinking 15% of its milk, of its body weight, that's 7.5 kilos, which is essentially 7.5 liters. And if you think of a 100-pound person drinking 7.5 liters of water a day, they're going to be urinating very frequently and have a very dilute urine. So one of the most simplest things you can do with foals, if you're trying to assess whether or not they're adequately intaking food, is to monitor their urine production and also monitor if they are, if it's dilute. So it should have a specific gravity 1006 or 1002, that type, and should be very dilute. If you see a foal posturing to urinate without production of urine, that's a problem. The two things we worry about, one, sometimes after foaling and breakage of the placenta, there can be hemorrhage in the bladder secondary to that urachal tear. That can cause a cystitis and may cause them to strain and pass a little bit of blood. The bigger concern is ruptured bladder, which can occur in looks to be a normal foaling. So if you're not seeing urine production, this is something you should always look for. And it's fairly easy to do in foals, just to slap an ultrasound on their abdomen and look for a bladder. The umbilicus, again, the placenta should separate fairly quickly. It should stop bleeding. You should not have to tie it off in a normal situation. Obviously, there's times where it's not normal, in which it might require to be tied off. But again, in general, we do not tie them off. We allow them to tear and contract and stop bleeding. We do dip neonatal foals umbilici, particularly if they're in the hospital. Foals that are recumbent and laying down longer than they should often develop umbilical problems because they're laying down, and that pressure often causes the umbilicus, the urachus, to reopen, and they'll develop a patent urachus. And so because of that risk, we dip their umbilicus fairly regularly in the hospital and recognize that this is a common complication of a sick foal that is spending more time down than he should be normally. Most of the time, if there aren't other factors associated with the patent urachus, time and curing of the underlying illness so that the foal is up more will resolve the patent urachus. However, when you have a patent urachus, it is critical to remember that that is an orifice of entry of bacteria. And so a foal with a patent urachus should be on some sort of antibacterial therapy until that urachus closes up. And in some situations, it becomes incumbent to take that umbilicus out, so to surgically remove it if it doesn't resolve or if there's other evidence of infection of the umbilicus. As far as dips, we tend to use chlorhexidine, which is Novosan, and diluted at a 1:4 dilution. That's been shown to be one of the safest. It's not caustic, so it doesn't necrose the umbilicus, but it's antibacterial. You can use 2% iodine. You do want to avoid the tinctures of iodine. They are very irritating and can cause skin injury. And the picture on the bottom here is a foal that got tincture of iodine accidentally splashed all over its body, and the area that looks discolored or whiter is actually edema because it had such caustic injury to the tissue. We do ultrasound the umbilicus of every foal that comes in the hospital to give us a baseline to see whether or not it looks abnormal. Most average size foals, about 50 kilos is what I would consider average, should have an umbilicus that measures about 2 centimeters, and each artery and vein should measure about 1 centimeter within that. If you see a vein or an artery that's enlarged, depending on how big it is important to monitor that, because if that's infection, that can be a source of seeding of other organs, particularly the joints. And so finding an enlarged vessel does not necessarily make an immediate surgical need. However, if that continues and the foal is showing signs of sepsis, sometimes we do recommend that the umbilicus is removed just to minimize the risk of a bacteremic episode. These are somewhat unusual, but something to consider. Remember that in your physical exam, that musculoskeletal issues are more than just potentially make it difficult for them to get around. If a foal has musculoskeletal abnormalities such as angular limb deformities or flexural limb deformities, they may not be able to rise and get nutrition. And so it becomes incumbent upon us to ensure that they get colostrum and nutrition. And when these foals are struggling to rise, holding them up while they're trying to nurse, it's really critical to make sure that they can nurse. And sometimes I would argue that it's safer just to put a stomach tube in and feed them through a tube, because suckling is a very complicated process, and anything that causes the foal to get weak or have other illness often causes the suckle to disappear. They may appear like they can suckle, but they may have an inadequate suckle, and they may actually be aspirating milk as they try. So in these cases, like this foal down on the bottom right is a little miniature foal with bilateral patellar luxation. So he could not completely stand up on his hind feet. This foal actually was quite capable of walking around, even though he could not extend his stifles completely. And ultimately, we were able to repair this surgically. But ensuring that they can nurse or just being safe and placing a stomach tube is indicated. So I mentioned prematurity earlier. So the definition of prematurity is gestational length less than 320. But you can see evidence of physical prematurity in foals that are normal gestation length. So bottom line is you should evaluate the physical parameters of this foal, and in some case potentially do diagnostics to evaluate it further, but to assess whether or not they have evidence that their organ systems have not had a chance to mature appropriately. This foal is a classic for a premature foal in terms of external characteristics. He's got a very domed forehead. He has very fine, soft hair. He's got curled ears. He's very lax, which is why he's recumbent, and he's small in body stature and unable to stand on his own. As I said, remember that when you see external signs, consider that there may be other organ systems that we can't see that are premature and that their function may be compromised. So, for example, with the GI tract, if the foal is born prematurely, we know that there's a chance that they do not have the specialized enterocytes that are needed to absorb colostrum. Those enterocytes develop in the last part of gestation. And if they do not have those enterocytes, then they're not going to absorb colostrum. And you can feed it to them, but they're still going to have failure of passive transfer. In addition, if their GI tract hasn't developed completely, they may not be able to ingest and absorb nutrition well. And in that case, if you feed them aggressively, you may result in colic and or diarrhea. And this picture on the bottom is an ultrasound image. This is the stomach of the foal. It's quite enlarged and fluid-filled. And then these small structures here are the small intestine. And the interesting thing here is that they're fairly distended, and it's a picture, so you can't tell that they're amotile, except for the fact that the one on the bottom right, actually the ingesta within it has actually settled out or stratified. When you see this stratification instead of a well-mixed ingesta, that's telling you that that intestine is not moving well. The skeletal system, in reality, even though you would think this is not a big deal, is actually a really critical part of prematurity. If their skeleton is not completely formed, they often have incomplete ossification of the small bones of the hocks and the carpi. The picture on the bottom here shows a hock of a premature foal, and you can see there's very small centers of ossification of the tarsal bones. They are not completely ossified. Even the upper picture, there's more ossification, but they are not complete. They're rounded on the edges. The concern is if these foals get up, because this rounded area without ossification is cartilage, if they run around, they're going to crush those soft cartilaginous precursors and develop essentially cartilaginous abnormalities that are eventually going to progress to arthritis. And so when we see these types of abnormalities on radiographs, it is really critical to try to minimize any kind of compression of these small bones until they completely ossify, which, if it's as severe as the foal on the bottom, can be several weeks to months before this is normal. This becomes a huge management issue because essentially you have to try to keep this foal from getting up and running around. If you're in a well-organized hospital, quite honestly, many hospitals will have volunteers that come in and just sit with these foals and keep them recumbent and allow them maybe to get up for a minute, standing quietly, allowing them to exercise. The other thing you consider doing, and which is a little bit tricky in that you have to place them well, is to apply tube casts that minimize any kind of compression, craniocaudal or lateral medial. These are much easier to do on the carpi, and I'll show you a video of a foal with those a little bit later to try again to minimize any abnormal forces crushing the cartilaginous areas of these bones until they completely ossify. At our veterinary clinic, we've had a few foals with this problem that we've actually put in the small animal underwater treadmill. The value of that is that it allows them to weight bear with only a percentage of their weight because the water is buoyant and holds some of their weight. And so they can actually exercise a little bit in the treadmill, the underwater treadmill. They can walk, which allows them to help build and strengthen the muscles and the soft tissue structures without crushing these cartilaginous precursors. Obviously, we're lucky we have a tertiary referral hospital with an underwater treadmill. However, it is expensive to do that, and it does require certain cases because you have to be able to manage the foal so he doesn't injure himself in the treadmill. These are just a series of pictures kind of showing normal behaviors in foals. They should be able to run around and play when roused, ears up, quick alert, looking at me, nursing kind of behaviors, as opposed to abnormal. The sleepy foal is probably the biggest one. Recognizing these foals are kind of, I'm standing there taking a picture of this foal in the upper at the 12 o'clock position. And the term, the lights are on, but no one's home would be good. He's completely unaware that I'm there. He's got an abnormal posture. His ears are lateral. He's somewhat obtunded in his mentation. Similarly, this little guy at about 2 o'clock, ears are lateral, kind of lethargic, tongue sticking out on the one in the center. This little guy down on the right is completely non-responsive, obviously. And then these two on the left-hand side are showing signs of abdominal discomfort. And so all of these it's important to try to educate your clients to recognize when things don't look right. Maybe it is possible that the foal is sleepier than normal, but I would never, ever assume that. I would always want to do a physical exam and really evaluate that foal carefully to make sure I'm not missing something. Post-foaling, I'd like to talk a little bit about nutrition. Obviously, we'll talk about the importance of colostrum, but in general, just getting nutrition into a foal is important. Foals are born, so a normal term, healthy foal is born with enough liver glycogen to provide energy to keep that foal nursing and moving around for somewhere in the 12 to 24-hour period. And that's if everything is good. And we're talking about a normal environment, not being born when it's negative, below zero out in the snow in Michigan, northern Michigan. So this is kind of an average. We don't actually know if a foal's born prematurely, do they have enough glycogen? If a foal is born septic, etc. So in reality, we probably think they have enough glycogen for a few hours. And so it's really critical that they get nutrition in, because hypoglycemia, once it develops, starts kind of a snowball effect, because if they're hypoglycemic, they become weak, they become hypothermic, they lose their ability to have a nice coordinated suckle. They lose the energy to be able to get up and nurse. And then these can lead to problems like further hypoglycemia, aspiration pneumonia, etc. So colostrum is very important, again, because of the antibody that it provides, but it's also a very energy-dense food. And we know that colostrum has about 2 times the calories of regular mare's milk. And so getting food, whether it be colostrum or mare's milk, or if in a pinch, passing a stomach tube and going to the store and buying some milk and giving the foal the milk is really critical to make sure that they have some energy. If the foal is sick, I'm not going to want to give a large amount because I don't know if their GI tract is capable of digesting it. But placing a tube and giving small amounts, maybe 200-300 mils, and assessing how the foal responds to it. Does it get colicky? Does its GI tract, gut sounds improve? You can always give more, is really important. Obviously, the other aspect of colostrum is the antibody. We know that the placenta in the horse has too many layers, essentially, and there is no antibody transfer across the placenta. So colostrum is the sole source of antibody for the neonatal foal. It's also important to remember that actually ingesting colostrum, so drinking that colostrum and having it coat their GI tract, actually has a local protective effect in the GI tract. And we recognize that the GI tract is the #1 route of infection in neonates, not the umbilicus, the GI tract. The umbilicus can be a problem, but again, with some of these farm diseases we might talk about later, it's really critical to get that colostrum in early before that animal potentially gets exposed to a pathogen. The other thing about colostrum is it primes the naive neonatal immune system. The neonate is born with a complete immune system, but it hasn't been activated. And certainly it has innate immune system. It needs to develop the non-innate immune system when it gets exposed to various pathogens. But that immune system needs to be primed and activated. And some of the enzymes and antibodies in colostrum actually prime or activate that innate immune system. Again, we know colostrum is absorbed by a special set of enterocytes that have receptors on them that have this non-specific binding of the proteins, and then they pinocytose it. These cells are hopefully there when the foal is born, the healthy term foal, but they are going to be shed just as a normal life cycle of any cell. In about 24 hours, you'll have complete loss. And that's why colostrum absorption is this critical window. Ideally, absorption peaks at about 8 hours. So we generally say ideally, we'd like to get enough colostrum in 8 to 12 hours, but generally it's probably up to 24. Again, we don't always know if these cells are actually there. If we have a premature foal or a foal, let's say, that had a dystocia and had profound ischemia, I'm sure you all know from your studies that if you have extreme blood loss, human, horse, whatever, as your blood volume decreases, your body, using the autonomic nervous system, shunts blood to critical organs like your heart, your brain, and your muscles. At the same time, it restricts blood flow to less critical, like the skin and the GI tract. Similarly, if a neonate has a dystocia and has ischemia and hypoxia, the same thing is going to happen. And so the GI tract is going to face ischemia more severely than the heart is or the musculoskeletal system. And so a foal with a prolonged dystocia may be born and have a GI tract that is significantly damaged and is going to slough a lot of those cells. And so it may be born term, but during that dystocia, the injury results in loss of these cells, and so they no longer have the ability to absorb colostrum. Remember, this absorption is nonspecific. These enterocytes grab various proteins, and you want them to grab antibody, but they can grab other proteins like bacterial toxins. And so closing the gut or preventing absorption of potentially pathogenic toxins is important as well. When we talk about failure of passive transfer, sorry, I didn't spell that out. So FPT is failure of passive transfer, so inadequate colostrum ingestion or absorption. There's 3 possibilities for why this happens. There's the lack of production, the lack of ingestion, and the lack of absorption. So failure to produce it, when we think about lack of production, we think about potentially mares that are premature foaling, so they haven't had a chance to even bag up and produce colostrum, or potentially a mare that leaks prematurely, has placentitis, etc. We do recognize that very young mares and very old mares are more likely to have poor quality colostrum. And poor quality colostrum is considered colostrum that has less than 3,000 milligrams or 3 grams per deciliter in it. This, if you measure colostrum with a colostrometer, will be less than 1060 in terms of the specific gravity. Failure to ingest can be because the foal's rejected, the foal's too sick or to stand or nurse, or there's some loss of colostrum, premature lactation. I'm sorry, the last possibility is failure to absorb it, and this is what we were talking about where we don't have those specialized enterocytes. The problem with this is that we don't always know it. So we may have great quality colostrum, we measured it, it's over 1060, the foal ingested 1 to 2 liters, and yet he doesn't have adequate colostrum passive transfer because he doesn't have those specialized cells. Sometimes we don't know this because the cells aren't there. Other times it's possible that it happens because by the time he gets the colostrum, it's too late. And because this is the area where we can't actually know, we've measured the colostrum, it appears normal, appears to be good quality, we've fed it to the foal, so we know he ingested it. We still can't guarantee he's had adequate passive transfer, which is why it's very important to test colostrum and ingestion by measuring IgG in that foal. So what is adequate IgG? Again, failure of passive transfer in humans is associated with an increased risk of sepsis, but it's not actually directly correlated. What that means is that in a well-managed situation, not having the adequate amounts, and I put adequate in quotations, doesn't necessarily mean you're going to get sick. In a well-managed situation, and this has been shown in horses too, in a well-managed stud farm, you can actually get away with less colostrum and still have most of your foals be healthy. So in one study that looked at this, farms that just simply checked to make sure their foals got IgG, those foals had better outcomes than farms that didn't, which makes sense because there's an increased awareness of that maybe foals that had less than ideal amounts. And so you hopefully institute higher surveillance or maybe give them something to bring their IgG back up. In a well-managed foal, a well-managed farm, IgGs of 400 were actually acceptable. This 800 milligrams per deciliter, which has kind of been in the literature for a while as the acceptable or adequate passive transfer, is a number that was somewhat pulled out of a hat. It's still a good number to go for, but remember that there are times where not having 800 is not necessarily indicator that this foal is going to get septic. So despite all this information that maybe we don't have to give every foal a complete passive transfer, we do know that failure to ingest colostrum is a risk factor for sepsis. And so our goal is always going to be to try to get them adequate passive transfer. To get an IgG of 800 milligrams per deciliter, you want the foal to ingest approximately 0.8 grams of IgG per kilogram of foal, which means, again, your average 50 kilo foal, that's 40 grams. If you measure the colostral quality and it has a specific gravity greater than 1060, so it's fairly thick and dense, that equates to greater than 30 grams of IgG per liter of colostrum. And so in this situation, if I had a 50 kilo foal, if I gave them 1.3 liters in the appropriate time, they would have adequate passive transfer. To measure colostrum, there's two methods you can use. You can purchase a colostrometer. They are available. There are two types of colostrometers. There's colostrometers that are typically used for dairies and colostrometers that are used for animals that produce less milk. So in a dairy, they actually use colostrometers where they put the colostrum in a beaker and then they use a weighted measuring tool, which is this picture down here, and they drop that into the colostrum. If the colostrum is really dense and good quality, this is going to not sink as far as it will if the colostrum is poor quality. And so the lines up here will correlate to the quality of the colostrum. And so good quality will be down around here. If the colostrometer sinks further in the milk and the milk ends up here, that's poor quality. In mares, we do the opposite. We take the beakers full of deionized water and we fill an instrument that looks like this with the colostrum and we drop it in the water. And similarly, although the opposite, if it's really dense, it's going to sink further and be measured. And so you just look at the scale on the side. The other way to measure colostrum, if you can't access a colostrometer, is to get a refractometer that's used to measure sugar content of wine. That type of refractometer can be used to measure the specific gravity of colostrum as well, and that may be an easier tool to purchase. So we know that the levels of colostrum peak about 18 to 24 hours, so we usually recommend that the foals get tested about a day of age. One thing to note is that measuring total protein on a foal does not correlate to passive transfer. In cattle, that has been shown. So you can actually just pull blood and measure a total protein and correlate that with the passive transfer for a calf. So if it's low, that suggests that they have poor colostral transfer. That does not work in foals. So in foals, we actually have to do one of multiple tests. Out in the field, the tests that are probably the simplest to use are things like what's called the zinc sulfate turbidity test or the glutaraldehyde clot test. These are relatively easy to set up and inexpensive to use and very, very accurate. If you have a clinical lab local that runs it, you can also run what's called the RID assay, which is used in most clinical labs. But quite honestly, the zinc sulfate test, which essentially you set up a series of dilutions of zinc sulfate, creates a turbidity to the fluid, And then similarly, you process the colostrum and compare the turbidity of the colostrum to the zinc sulfate, and you get your assessment. Very accurate test, very inexpensive. And if you train your nurses in how to do it, it's a much easier and simpler test than some of the others. So what if you have failure of passive transfer? So you have a foal, it's now over a day of age, or we'll start first with a foal that's less than a day of age first. What are your alternatives? If you live in an area that has a thoroughbred or horse breeding farms where you have a lot of breeding going on, best thing you can do is establish a frozen colostrum bank. So to do this, you would milk colostrum so a foal would be born, it would get up and nurse from one nipple. After it's done that, you would milk 200 to 250 mils from the opposite teat, measure the quality to make sure it's good quality, test it to make sure it doesn't have any alloantibodies that could cause NI, and then freeze it in ideally a -20 freezer. If you establish a frozen colostrum bank, you then have the ability to use that if you have foals that didn't get adequate colostrum. And in many of the big breeding areas in the U.S., hospitals actually establish a colostrum bank. Clients can actually collect the colostrum, they bring it in, the hospital tests it, maintains the frozen bank, and then if that client a couple months later has a foal that did not get colostrum, they can go and buy back that colostrum. So they get sort of a credit by giving it, and then they can utilize colostrum from that frozen bank. So that's probably the best method, if you can do it, is to try to collect colostrum from horses, make sure it's good quality, and freeze it, and then have it to give. We generally recommend that it be frozen in a -20 Fahrenheit. I apologize, I don't know what that is in Celsius. And that it be only kept for about a year. After a year, I would still use it in a pinch if it's all I had. But by doing this, you set up a sort of a protected bank for your clients to use should we need it. Because the number one ideal goal would be to get colostrum into that foal's GI tract, again, because we've talked about the local protective effects that it has. If you don't have colostrum, equine colostrum, you can use bovine. It will be absorbed if it's in that window of time, and it will have non-specific protection. The Fc receptor on these antibodies will potentially prime the immune system, so it may help activate the innate immune system. Obviously, it doesn't have specific antibody against equine diseases. It's only against bovine diseases, and so it's not going to be perfect, but it will prime the immune system, and it will coat the gut. And you will also provide some of the other things like enzymes like lactoferrin, et cetera, that are so critical in colostrum. It does have a shorter half-life, but at this point, that's probably not a major concern. There are commercial colostrum replacements that are available. My one concern about them is to recognize that most of them are called supplements, not replacements. Most of them do not provide enough IgG. And remember, I said that ideally we want 0.8 to 1 gram per kilogram of foal. So if you're using a commercial colostrum replacement, check the IgG quantity and make sure that it's going to be acceptable. If you have none of these sources and you can't afford plasma, etc., it isn't unreasonable just to feed that foal milk without colostrum, without antibody in it. That will help coat the gut and close the gut. And then if you're concerned that this foal lives in an environment or has risk factors for sepsis, put that foal on antimicrobials until you're confident that he's either thriving or his active immunity has begun. Remember, active immunity develops as they grow up, but it is blocked by passive immunity. So foals don't really start to develop their own active immunity against pathogens they see until the passive or the colostral antibodies start to decline. And so if a foal gets plenty of colostrum, that active immunity starts to significantly come up in the 2 to 3 month range. If you have a foal that did not get colostrum, their active immunity starts to develop at an earlier age, and so they will actually start to have antibody production against the pathogens they're exposed at an earlier age. And so while not getting colostrum certainly has its concerns, it's not actually a bad thing, other than you need to make sure that that foal is in a well cared for environment, not exposed to any significant pathogens. And if it shows any signs of illness, you're probably going to want to cover it with some sort of antimicrobial therapy to prevent a higher risk of that foal getting septic or ill. Obviously, plasma is the other alternative to give appropriate IgG, passive immunity to a foal. There's you can buy commercial plasma. It's the nice thing about commercial plasma is it's collected from animals that have been hyperimmunized to some of the pathogens we see in foals. In general, we consider that 1 liter of plasma should raise the IgG in a healthy foal about 200 milligrams per deciliter. So in reality, depending on what the foal ingested, where its IgG is, you potentially are going to give 1 or 2 liters. If you give more than that, you need to make sure you do it over time, because that is a significant volume expansion and can cause fluid overload. You can also consider preparing your own plasma. You want horses that are EIA negative, so equine infectious anemia negative. You ideally, if possible, you want to check them for the big blood types that can induce NI, so they're AA and QA negative. But in a pinch, you may have to use an animal that you can't blood test for these. Collecting it usually, so when we collect blood from horses, because of the fact that their red cells like to stick together, they sediment fairly quickly. And if you let it sit for 24 hours in a bucket, it will collect it into a bag and then with an anticoagulant and let it sit. It'll sediment out, and you can decant the plasma off and use that to give to a foal. When you give plasma, you want to give it using a transfusion set. You want to make sure that you give it slowly initially to monitor for any kind of transfusion reactions. We typically monitor their heart rate, respiratory rate, and temperature, and look for things like hives or other signs of an allergic reaction. If you slowly start it like that, and after 5 to 10 minutes, you're not seeing any reactions, you can increase it and gradually increase it, monitoring them. Remember, if a foal's in renal failure, you need to be very careful, or it's very compromised, because you don't want to volume overload them. And if you're giving plasma over prolonged periods of time, so you're keeping the foal from nursing, etc., remember that they can get hypoglycemic, and so you may want to supplement them as well. So moving on to the sick foal, what do you want to look for when you see a neonate that is, what are some of the symptoms that we see, some of the subtle signs? One of the problems is that many times in the early stages of illness, the signs are subtle, and so clients may not actually recognize that this is a problem. They may just appear sleepy. The mare's udder might be distended. That's often a great clue that the foal's not nursing well. One thing we know with foals is a lot when they're sick, they may actually get up and walk over and butt the mare's udder and stick their head under there, but they may not actually latch on and nurse well. And so it's important to actually look and watch and make sure that you see them latch on. And then you can simply put your hand on their neck and feel them swallow. While you're doing that, if you have any concerns, stick your stethoscope on their trachea to see if they're aspirating any milk. Because sometimes if they have a problem with their suckle, they actually will swallow but aspirate at the same time. So they may have milk going down their esophagus and their trachea. If you hear milk in their trachea, they need to be cut off from nursing, and you need to place a nasogastric tube and feed them via a nasogastric tube until that resolves. One of the clues for this is sometimes you'll see foals and they have milk all dried on their face because they're sticking their head under there, they're butting the udder, which is causing letdown, and milk is streaming out, but they're not actually nursing. So seeing all that sticky milk on their face should alert you and the owners that there's potentially a problem associated with this foal's nursing. If a foal has an inadequate suckle, so if it's not nursing well, you're seeing that it's not really latching on, again, you should immediately stop letting him nurse, because aspiration pneumonia is the #1 organ system we see affected by sepsis. And there's a fairly significant mortality rate if that's not controlled. In these situations where a foal's not nursing well, you're going to want to muzzle the foal or separate him from the mare and place a nasogastric tube and feed him via nasogastric tube. As the foal gets better, you can assess if the suckle has improved over time. Usually we wait till the foal is thriving. We feel like the major illnesses are better. He's getting up. He's aggressively trying to nurse. When I first want to check if a foal can suckle normally again, typically what I do is first of all, I feed the foal some milk by stomach tube so that they're not as hungry. They're maybe a little hungry, but not ravenous. I milk the mare out so there's not a lot of milk in there. So if he goes to nurse, there's no risk that she'll let down large volumes and he'll aspirate them. And then while I let him nurse, I place, again, my stethoscope on the trachea and listen to hear if I hear any milk going down his trachea. If I hear milk going down, I stop and I give it a few more days and try again. If, on the other hand, I don't hear him aspirate, then I feel more confident that we are able to stop feeding him by stomach tube and allow him to nurse. If you place a small stomach tube, foals can nurse with the stomach tube in place, so you can actually challenge them and let them nurse a little bit and leave the tube in and continue to support them through the stomach tube. So let them have a little bit of milk over time, and if they continue to do well, gradually let them ingest only through by nursing and remove the stomach tube. So loss of a suckle reflex is often one of the early signs we see with septic foals, but as I've just discussed, it's often missed by clients, which means the foals, one of the more common reasons they present is for aspiration pneumonia. Another sign you might see is they start to lose their affinity for the mare. They may wander off or be less willing to follow her or stick with her. Remember, with infection in neonates, they often can have a normal temperature. So this idea that if they're septic, they should have a fever, you should just not go down that road. Foals that are septic, they can have a fever. They can also be normal or even hypothermic. If you imagine, if they're septic and they're not nursing well and they get hypoglycemic, they're going to get hypothermic. So not finding a fever does not mean you can rule out an infection in a neonate. So one of the first diseases I wanted to at least mention is what's called neonatal encephalopathy or dummy foal syndrome. There's a lot of terms for this disease. Perinatal asphyxia syndrome is probably the overarching. It simply means that there's been decreased oxygen delivery to that foal in the perinatal period. Neonatal encephalopathy simply refers to one specific body system, so the brain or the central nervous system, because when they have decreased oxygen delivery, we often see that they lose some of their normal brain function. And so these foals are often obtunded, they may have abnormal behavior, and they lose their suckle, are the three big ones. Again, remember, with perinatal asphyxia syndrome, other organs can be affected. So the GI tract may be affected, the lungs may be affected. So it's important to think big picture. But in terms of the term dummy foal, these foals are called dummy foals because they appear to have an abnormal mentation and behavior. If you think about the pathophysiology of oxygen deprivation, there is a period of time where that loss of oxygen and ischemic injury to cells results in cellular death, changes in membrane channels, edema, and inflammation. In the brain, that edema and inflammation causes swelling. And again, because it's encased in a bony calvarium, that pressure is what makes the signs get worse. That is inflammation, ischemia, neuronal death that sort of progresses over time. And so many of these foals will be born and appear normal at birth and have a decline in their mentation over the first day of life as these changes occur. And so if you have a foal that either has a dystocia or some delayed parturition, or a foal with a history that it was normal at birth and now is not acting normal, this has to be on your differential list. However, the other big thing on your differential list is sepsis, because this is a classic presentation for a foal that's gotten an infection. And so when we're presented with a foal that shows signs of, let's say, depression, poor suckle, maybe organ system dysfunction, colic, diarrhea, respiratory signs, it can be due to hypoxia or ischemia, but it also can be due to sepsis. And it's very difficult to differentiate these two. So if you have a foal presented like this, unless you clearly have information that you know it's not septic, we always recommend that you cover this foal with antimicrobials because of the risk that sepsis, if it's allowed to progress, has a poor outcome. Now, I'm not going to spend a lot of time talking about this, but again, the dummy foal or the perinatal asphyxia syndrome, in some cases, this is due to loss of decreased oxygen delivery during either pregnancy or parturition. But there is some data out there currently that suggests there may be abnormalities in neurosteroid hormone production or development in utero, and that these alterations in neurosteroid hormone may be one of the reasons that these foals are born abnormal and have mentation abnormalities and are dull and difficult to rouse. Again, this is one of your big differentials, but sepsis should always be the other. These are 3 pictures of foals, just to kind of give you an idea of, again, this foal in the upper left, his ears are kind of curled in, his tongue is sticking out, his head's sort of level with his body, kind of looks a little bit slow. Similar to this foal on the right, he's standing in quite an abnormal position. And this foal on the bottom, ears are curved, tongue sticking out, clearly an abnormal position. These could all be foals that are what are called dummy or have neonatal encephalopathy. They could also be foals that are septic or have some other illness. I can't differentiate just by this appearance. This is what's called a neonatal sepsis score. This particular one was developed by the College of Vet Med in Florida. What a neonatal sepsis score attempts to do is help you determine the risk that the foal that you're examining has sepsis versus, let's say, it's just got neonatal encephalopathy. There's a series of information you plug into this score, and you get numbers depending on the severity. So to kind of go through this, on the CBC, you look at if you can perform blood work, you look at a neutrophil count. If it's very low, you get the number 3. If it's normal, you get 0. Again, if you see bands or immature neutrophils, signs of toxicity, or a high fibrinogen, these would all give you 2s or 3s. And then if they're normal, again, you get a 0. Hypoglycemia, colostral transfer, your physical exam, looking for things like petechia, fever, etc. The end result is you add up all these numbers. If they add up to greater than 12 in this particular score, there's a high risk that this foal has sepsis, and you should treat for the risk of sepsis. So in other words, cover with antimicrobials. So neonatal septicemia, it is the most common cause of death in neonates in the first 7 days of life. And septic foals have it depends on the paper you look at, can have as much as a 50% mortality rate. There are multiple causes of sepsis. So again, failure of passive transfer is a risk factor, but it's not the only reason. In utero infections, farm problems, umbilical problems, aspiration pneumonia, or poor suckle can all result in sepsis. Infection typically occurs shortly after birth, and as I've already discussed, clinical signs can be very subtle initially. And these foals can look just like your little neonatal encephalopathy foal. So the nonspecific clinical signs you might see, again, the sleepy foal, the distended udder, the milk face, loss of affinity to the mare. They may get dehydrated. You may see specific organ infection, lameness, diarrhea, increased respiratory rate. This fibrin in the anterior chamber, or hypopion, is as shown in this picture here. That should be a clue. You should always take a quick look with a bright light at the anterior chamber of a foal. If you see fibrin in there, that's strongly indicative that foal has an infection and significant inflammation. Injected mucous membranes, and then another really good thing to look for is petechial hemorrhages, either on the mucous membranes or the ears. If you shine a light on in the ear, like up against the ear, you will see if there's little petechial hemorrhages, and that is also a very strong indicator of sepsis. In terms of organ systems, remember the respiratory system is the most commonly affected probably because of two reasons. One, sick foals lose their suckle fairly quickly and are at very high risk of aspiration. The other reason is that the sick foal has that's laying down has poor lung expansion. So, and over time, if they're in recumbency for any period of time, they'll develop atelectasis. The reason that happens is that the chest wall in a neonate is very compliant. And so if you think about the adult horse in lateral recumbency or the adult human, we have a very stiff chest wall. And even if we lay down, that chest wall remains in the same shape. And so that pull of the chest wall and that negative pressure in the pleural space keeps the lung inflated. Neonates have a very malleable or compliant chest wall, and when they lay down, their chest wall collapses in. And so they are more likely to have collapse of their lung and actually go below what's called minimum volume and actually have alveoli actually close. So if they maintain themselves in lateral for any length of time, they'll start to get atelectasis on that side. And if you remember, every time you have to pull that alveoli open, it takes a lot more work than it does if it maintains some minimum volume. And so every time that foal is breathing, there's a lot more work of breathing to reopen that atelectatic lung. And as that lung opens up and snaps apart, there's irritation or frictional injury to those alveolar walls that results in inflammation. So now you have a foal that's recumbent. Maybe he's hypoglycemic, so he's not got a lot of strength. His lung is collapsing. He's starting to have to force these alveoli open. And there's irritation and friction and inflammation, which degrades surfactant. And then on top of that, maybe he's got a poor suckle, so he inhales a little bit of milk. This is all setting him up for perfect to ask for pneumonia. The other thing to think about is surfactant. So normal foals, after about 300, 310 days, should have adequate surfactant in their alveoli so that when they first inhale, that surfactant is spread around the alveolus, and it's hydrophilic with a hydrophobic side, and it actually repels itself, so it helps to hold that alveoli open and decrease the surface tension. It's similar to, it's not the same, but if you think about how much work it takes to blow a balloon up the first time, and then once it's blown up and you let the air out, it collapses, but it maintains a little bit of air in there. It's kind of the same idea. So surfactant decreases the surface tension so that our alveoli stays open. Now the second breath is much easier because it's already partially inflated. If however, I don't have surfactant, every time I breathe, my alveolus is collapsing down and I have to generate more pressure and work to inflate it. Primary surfactant deficiency, so lack of production, is very rare in neonates. Usually it's produced by 300 days of gestation. However, secondary surfactant deficiency is common because surfactant can be degraded by inflammatory cells, or if they aspirate meconium during fetal stress, meconium has salts and things in it that'll break down surfactant. So if those two things are happening, now you have breakdown of surfactant and you have an increased work of breathing and a higher risk of collapse of those alveoli, all of which predisposes this foal, who may have a weak suckle, to aspiration, to pneumonia. The GI system is probably the second most common place where we see sepsis. Colic and diarrhea would be the most common clinical signs. Remember, foals don't colic like adult horses. We're trained to think of somebody pawing, laying down and rolling up on its back, those types of things as a sign of colic. In a neonate, you can sometimes see those things, but many times the neonate with an abdominal pain is just fussy, similar to human babies. They may just be constantly moving kicking, just fussy, unable to settle. You set them up, put them in sternal, and 2 seconds later they're on their side. When you have that kind of repeated movement and agitation, you should think about colic, because that is often one of the signs we see with neonates. If the GI tract has got either sepsis or ischemia, it's very problematic, because it does mean that you have to be very cautious about the nutrition you provide via the GI tract. Again, if your enterocytes have been damaged, whether it be to a bacterial pathogen or ischemia, they're not going to be able to absorb the nutrition like they should. And if those carbohydrates and proteins pass down into the large colon, they're going to actually stimulate osmotic diarrhea and colic, so gas dissension, etc. So in foals with GI disease, while we always want to feed them, you have to be very cautious about how you feed them. And we'll talk about that a little bit later. And in some cases, you may want to try to provide nutrition intravenously during that early period while you slowly assess whether or not the GI tract can handle nutrition. Joint infections are seen in about a quarter of septic foals. This is generally considered a medical emergency, because the longer a joint is infected, the more damage to the cartilage and the more long-term risk of them having lameness. Usually it's secondary to bacteremia, so whether it be from the lung or the GI tract or the umbilicus, they have a bacteremic episode and it seeds the joints. Classic clinical signs are joint swelling. Usually there's some edema associated with it, and the foal is usually lame on it, as opposed to swelling where it's cool, there's no edema and no lameness. That may be less likely to be septic. The reason this is a medical emergency is that we need to flush or lavage that joint as quickly as possible. You can flush it like this picture with just needles. I would always collect a sample first so I can evaluate the protein and the cell count in it, because you're going to use that information to determine how the joint is responding to treatment. In animals where the sepsis is advanced and there's a lot of fibrin, arthroscopy or arthrotomy may be necessary to get that fibrin out, because that fibrin is often a nidus of bacteria. And even with the best flushing and antimicrobial therapy, if you have those clumps of fibrin with bacteria in them, you're not going to resolve that infection. And so sometimes in these cases, we actually, if we have the money, we will do an arthroscopy. If we don't have the money, we'll actually do an arthrotomy and treat this joint almost like you would an abscess of the skin. So you're going to open that joint, make a hole in it, lavage it, and then wrap it in sterile bandages and allow it to weep. Actually, that drainage, that continuous drainage of fluid out of the joint is very good for cleansing. But remember, if it continues to drain, you're going to have to change the bandage frequently, because you don't want that bandage to soak through, because once it strikes through, it's a potential source of more contamination coming into the joint. So if you're faced with a foal with septic joints and you can't, you know there's fibrin in there and you feel like you're not getting a good flush with needles, consider doing an arthrotomy and actually putting a hole right into this joint, flushing it, and then bandaging it heavily and doing bandage changes as needed to prevent strike through. I've already talked about this. Osteomyelitis is another cause for lameness. This can be difficult to differentiate. And remember, many times if you have a septic joint, you can also have osteomyelitis of the bones associated with that joint. The best way to determine osteomyelitis is to radiograph the legs. But remember, because foals are still developing their ossification, their bones look really ugly. And so you should always radiograph both the abnormal and the normal leg, because you need to compare them. Because many healthy foals, their physis looks like it's infected, when in reality it's just ossification process. If you have osteomyelitis, if possible, consider regional limb perfusion to try to treat that. It's a more effective way than just IV antimicrobials. You may, if there's, depending on the severity, need to go in and debride that infected bone. With osteomyelitis, you're talking about long-term antimicrobials, minimum probably 4 to 6 weeks, and regional limb perfusion and repeat radiographs to assess the progress of it. This is a really difficult and expensive thing to treat in foals. And so again, trying to prevent it should be the first goal of any veterinarian. Umbilical infections occur in about 25% of foals. They do increase the risk of septic arthritis and osteomyelitis. As I've already mentioned, we ultrasound the internal structures of every umbilicus in a foal that comes in the hospital. Normally, all the vessels should be about 1 centimeter and the internal stalk about 2.5 centimeters. My rule of thumb is in a healthy foal, by about 7 to 10 days, I have a really hard time finding a normal umbilicus on ultrasound because it's shrunk so much. So if I'm 2 weeks out and I can still easily identify it, that's abnormal. The decision on whether or not to take it to surgery versus treating it medically with antimicrobials has to be made based on other factors, whether or not the foal has other symptoms, whether or not he's thriving, etc. Many foals will resolve an umbilical infection with long-term antimicrobials, but in some situations, particularly if you think that that umbilicus is acting as a nidus to other sources, it may be better to just remove it and take that source of infection out of the equation. So septicemia treatment and support. So we've talked a little bit about different organ systems. So now I'm going to talk a little bit more about just kind of overall treatment. We may not be able to determine exactly what organ systems are affected. And so how do you go about kind of treating the suspect septic foal is the next part of this lecture. So specifically, obviously, antimicrobials are a really important tenet. Broad spectrum is important because many times we need to start antimicrobials now, and we don't actually know what the cause of the sepsis is. If you look in the literature and you look at what we know from various retrospective studies, about 50% of septic foals can have mixed gram-positive and gram-negative infections. And so when you are approaching antimicrobial therapy, it's probably best to use an antimicrobial that has spectrum against both gram-negatives and gram-positives. So some of the organisms we typically see are E. coli, Enterobacter, Actinobacillus, etc. And gram-positive streps, maybe staph, are kind of the typical. And so reaching for an antimicrobial that either has broad spectrum against both or combining antimicrobials to get this kind of spectrum is important. So for gram-positives, we would use kind of the penicillins or the ampicillins. So potassium penicillin or even procaine penicillin is a great choice. Ampicillin as well. Naxel or Ceftiofur is a great one. And Exenel or Exceed, which is a long-term Ceftiofur that is now on the market, I assume you guys have it in your country, is also an option. So if you are using Exenel, which is a drug that allows you to, it's a long-acting Ceftiofur, so you can inject it and then 4 days later do another injection and then once a week do an injection. That has been shown to be effective against most streps that we see in large animal species. In neonates, if you're trying to use it as a broader spectrum, so Ceftiofur at higher doses can have some gram-negative spectrum as well, it's important to use it as a higher dose. So in adult horses, in neonates, we would double the dose and double the frequency in a neonate. So we would go double the dose and repeat it in 2 days instead of 4 days. That will give you a better spectrum against gram-negatives than using the normal dose. For gram-negative spectrum, again, high-dose Ceftiofur, Genicin, amikacin, and other cephalosporins like cefotaxime. Remember with the aminoglycosides, so Genicin and amikacin, we have to worry about nephrotoxicity, and so we need to use these in consideration of the foal's fluid status and renal function. Blood cultures are a great aid to treatment. They allow you to determine, one, if there is bacteria there, and two, what kind of pathogens you're seeing. But they do take several days to come back. And so waiting for a blood culture to institute antimicrobials for a neonate is a bad idea, because by the time you get the results, if that animal was truly septic, you're already several days behind in terms of prevention and treatment. Other therapy, when you have a septicemic animal, fluid therapy may be indicated. Kind of a fluid therapy maintenance dose for foals is about 4 mils per kilogram per hour. Remember to include in that fluid therapy, if you're giving oral fluids, those are fluids. And so if you're feeding a foal, you may not need maintenance fluid therapy. In the acute presentation of a foal, if they look like they're hypovolemic, we usually start with about a 10 to 20 mil per kilo bolus over 20 to 30 minutes, and then use that to assess response. You want to be careful about giving large volumes of fluids to neonates. They do tend to have more fluid reserves than the adult horse at birth, and they are more susceptible to volume overload. And so when you are treating a foal that you think might be hypovolemic, use smaller volumes and reassess. So a 20 mil bolus or 10 mil bolus, which would be a 500 to 1,000 mils over 20 minutes, and then reassess them. Has their heart rate gone down? Are their extremities warmer? Are they more alert? Is their bladder filling up like they're producing urine? If not, then maybe another 10 to 20 mil bolus. So just be conscientious of the fact that they can have fluid overload, particularly if they're septic or in shock. And so we need to be careful. Sometimes in foals with septic shock or come in hypovolemia, I will start them on plasma because that allows me to, colloids offer some benefits over crystalloids. They stay in the intravascular space better. They also provide antibody if the foal's got failure of passive transfer. Start them on colloids while at the same time maybe using smaller crystalloid boluses to try to determine how much they need to volume resuscitate them. Anti-inflammatories are always valuable when you have a septic foal. We know they have significant inflammation, systemic inflammatory response syndrome. Again, we want to be careful because of we know that many of the anti-inflammatories are nephrotoxic. So I will typically use about 1/4 to 1/2 milligram per kilogram and kind of use it as needed, or maybe a low dose twice a day. Again, being very careful to make sure the foal is volume expanded and has normal renal function. Keeping the foal sternal sounds silly, but it's actually a really critical part to management of the sick or septic foal. We know that if you take, again, I spoke earlier about foals' chest wall compliance. In neonates at birth, if you take a neonate, you sit them sternal and you get an arterial blood gas, and then you lay them in lateral and get an arterial blood gas, that blood gas will change by as much as 15 millimeters of mercury from sternal to lateral recumbency. Newborn foals are born somewhere with a PaO2 somewhere in the 60 to 65 range, which means they are just about to be on the steep end of the oxyhemoglobin curve, and that's pictured here. So they're born with a PaO2, at birth, their PaO2 is about 65 or so. So that puts them right here. They're kind of just at that area where if it drops, their saturation can fall pretty dramatically. If it stays up there or goes up, they're in the flatter part where their saturation's in the 90 to 100%, okay? So if I have a foal that's just born and its PaO2 is 65, it's sitting right about here. If I lay that foal in lateral, I know I'm going to drop it from 65 to 50, which now puts me down here in the steeper and saturations in the 70%. So the take-home message is keep your foal sternal. That is a really important way to maintain this oxygen. The other thing we talked about is that if it's in lateral, because of that compliance, the dependent lung is going to become atelectatic, increase the risk of inflammation and sepsis, but also decreases its ability to be effective at oxygen diffusion. So, simple thing, keep your foal sternal. If the foal's PaO2 is above 65, that may be enough. However, if you're finding that the foal is very weak with a PaO2 in the 60s, adding nasal oxygen can be really beneficial because it can push him up to this 80 or above, which puts him in the oxygen hemoglobin saturation of 90% plus. And that's really maximizing the oxygen delivery to his tissues. So now you're saturating in the 90s. If in addition you're maintaining good perfusion by adequate fluid volume, you're maximizing oxygen delivery to his tissues, which is going to ultimately help him survive whatever his underlying disease is. So take-home message, keep them sternal. You can use human pulse oximeters on their tongue or their vulva to assess their saturation. If their saturation is falling below the 90%, oxygen insufflation. And actually the nice thing about foals is you can stick bilateral tubes up their noses to the medial canthus, hook them up to oxygen flow at about 15 liters a minute, and you can really significantly improve their oxygen saturation. So unlike adult horses, where this is probably not going to have a significant difference, in neonates, oxygen delivery by bilateral insufflation tubes can really significantly impact their O2 delivery. Nutritional support. So we've talked about this a little bit, and I've mentioned that the healthy neonate at birth drinks about 15% of its body weight, so 50 kilo foal, about 7.5 liters. By a couple weeks of age, they actually increase this to the 20 to 25% amount. When we're talking about a sick neonate, we would love to say, okay, we want him to drink 15%, but that's probably not necessary, and we need to be cautious because we're not exactly sure if the GI tract can handle oral nutrition. There's a few studies out there that have tried to look at the metabolic rate of sick neonates, and what we know is that their metabolic rate in the foal that's either recumbent or ill and not moving around, maybe he's in a stall in an environmentally controlled hospital, their nutritional needs is actually less than the healthy foal, and is probably, if you turn it into percent body weight, somewhere between 5 and 10% of their body weight. So that means that the neonate that's sick, I can conceivably start much lower in my nutritional supplementation and allow myself to evaluate how the GI tract is handling that. And so for me, when I'm faced with a sick neonate, I usually start at about 2.5% of their body weight in milk a day, which in a neonate that's 50 kilos is going to be somewhere around 100 mils of milk every 2 hours, and look to see how they tolerate that. Again, if I'm giving nutritional support to a foal because I don't think they can nurse, they have a poor suckle, I'm always going to do it by stomach tube. We do not use bottles in our hospital because sick foals, if their suckle is poor, it's going to be poor nursing the mare or nursing a bottle. And so a stomach tube is, in my mind, a simple way to decrease the risk of aspiration pneumonia. So I'm going to start typically giving 100 or 200 mils of milk via stomach tube and assess in 2 hours whether or not the foal has absorbed that. I can aspirate and see if there's any residuals in the stomach, whether the foal is colicky or shown any signs that he's having problems tolerating that. If he tolerates it, then maybe the next feeding I'll bump it up a little bit. My first goal is to get to 5% of their body weight. My second goal ultimately is 10%, and I will do this very slowly, recognizing that they may not be gaining weight regularly, but they are probably getting adequate nutrition to maintain at that point. While the foal is in the hospital and is sick and spending more time recumbent, 10% is my goal. I don't go above that. Once they're feeling better, and maybe I'm starting to think about letting them nurse the mom, then we try to start to go towards that 15%. Once they're on their mother, again, that's up to them how much they drink. But that, to get back on their mom, they have to be vigorous and strong, and I have to be confident that when they suckle, they don't aspirate milk. Because it's hard to know if they can tolerate it, and so we're going to start very, very slowly, I would typically use IV dextrose as a short-term nutritional support. You can give them IV dextrose in a crystalloid for about 24 hours without getting into trouble or concerns about not providing other nutrition. Remember, dextrose is simply a carbohydrate. Foals need protein to grow, to develop their GI tract, their other organ systems. And obviously, in an ideal world, they also need fat because that's a very calorie dense. However, for the first 12 to 24 hours, while I'm trying to assess if their GI tract can handle nutrition, I will use IV dextrose as a short-term benefit. If it turns out that their GI tract cannot handle 5 to 10% of their body weight nutrition a day, then I would consider adding in more complex IV nutrition that includes amino acids, and then if I'm talking about long-term, would include lipids as well. But in the short term, so 12 to 24 hours, dextrose alone is simple. It is important, however, to remember to monitor their glucose, because septic foals will often have very poor insulin regulation, and they can go from hypoglycemic to hyperglycemic fairly quickly. And so giving dextrose is great, but you want to make sure that you're not causing hyperglycemia, because we recognize now that hyperglycemia is actually inflammatory and triggers systemic inflammation. And so our goal, while it's to provide nutrition, is not to make them hyperglycemic. One of the diseases you guys asked me to talk about was neonatal isoerythrolysis. So I will move on to a discussion of that now. So neonatal isoerythrolysis, which I will refer to as NI now, is an immunologic and a genetic disorder. So remember, it's immunologic because what happens is you have antibody binding to the antigens on the foal's red cells and causing a type 3 complex deposition. It's also a genetic disorder because it occurs because of a genetic conflict between the mare's blood and the stallion's blood. So, as a definition, it's really both. Remember, this is the sole period of life where exogenous antibody, so foreign antibody, enters the bloodstream of an animal, is this period of time where they absorb colostrum. And unfortunately, while we want them to absorb colostrum, in this situation, that antibody that they ingest actually attacks or binds to their own red cells and causes the breakdown of those red cells. So to kind of briefly review, there are several equine blood groups and equine blood factors. Not every factor combines, but if you look at this list here, you can imagine that there are many, many, many blood groups in the equine species, which makes it very difficult to come up with a true universal donor, unlike humans where we just have a couple of blood groups. However, we do recognize that with respect to NI, the vast majority of cases really only occur because of conflicts between two major blood combinations. The first one, I'm going to skip this, is factor AA. So this is blood group A, little a antigen. This is probably the most highly immunogenic factor that we see, and is one of two antigens that we see associated most commonly with NI. In this situation, the mare would be AA negative, so she lacks this antigen on her red blood cells, and the stallion would be AA positive. The second one is the QA factor. This is also highly immunogenic, but less so than AA. And again, the mare would be QA negative, and the stallion would be QA positive. The way this works, I skipped the first slide just because it's fairly similar, but the mare is thought, so generally NI does not occur in the first breeding between two incompatible mares and stallions. What happens in that first breeding is that probably some of the foal's red cells get into the mare's system, and her body recognizes that AA or QA antigen on that red cell as foreign and starts to produce antibody against that. So now you have memory cells that produce that specific antibody against that red cell antigen. However, they don't produce enough antibody that foal, when it's born and ingests colostrum, has any kind of significant hemolysis of the red cells. However, in subsequent breedings, again, breeding to a sire that has the antigen to a mare that doesn't, that's already been sensitized, now she gets exposed to that antigen again, and she has a more aggressive production of antibody. So now this antibody during late gestation is passed into the colostrum, and the foal ingests it. And then if it's enough, the foal will develop clinical disease. So because the amount of antibody that's produced is critical for development of disease, it may take multiple breedings before you see an NI foal, because it may be subclinical and not recognized, or there may be some other factors that play a role to suppress the NI, and we'll talk about that a little bit. When it does actually happen, so now we have the foals on the ground, it ingested the colostrum, it absorbs the colostrum, that antibody binds through its antigen on its red cells, and either by agglutination and breakdown in the spleen, or by direct hemolysis, those red cells are lysed and that foal becomes profoundly anemic. Clinical signs we see, again, the sleepy foal, because they're hypoxic, so they're weaker, they often have an increased respiratory and heart rate. They may have icterus and pale mucous membranes. You may see hemoglobinuria if there's extravascular hemolysis. Anemia, obviously, if you measure it clinically, and hyperbilirubinemia, because the hemoglobin is broken down to bilirubin. Because the severity of illness is going to depend on the amount and the type of antibody, clinical signs can develop in a broad range of time. I've seen foals present with profound anemia within hours of birth. I've also seen foals present at a week of age because they've had a very slow breakdown of their red blood cells, and so the anemia and the changes were not detected as quickly. So remember, even if a foal's a week of age, they can still have NI if the antibody is either the amount is low, or let's say it's a slow process of binding, agglutinating, and being destroyed in the spleen. So very variable presentation. But classically they present because they become so weak that their activity declines, and they're spending so much time to breathe that they don't really have the time to nurse, so they become weaker. If we look at the frequency in specific breeds, it does vary. It is more common in standardbreds than in thoroughbreds. Remember, mules have one of the highest rates, and this is because mules are a pairing between two different species. So mules are a pairing between donkeys and horses. And there's an antigen called donkey factor, which is associated with NI in mules. Besides the AA and QA, we do see NI with some other factors in horses, but these are much, much less common. But if you're evaluating a blood type in a stallion and a mare, you should at least be aware that there are some others. Interestingly enough, with all the variable antigens, you would think we would see NI much more commonly than we do. One of the reasons that we don't see it as commonly is that we recognize there are certain blood groups that actually are protective against it. What we think happens with these blood groups is that they may actually mediate either immunosuppression or somehow take these antibodies out of activity or prevent the triggering of hemolysis. One of the ones that we recognize is the CA and the C negative alleles. So if a horse has these antigens, they are less likely to have NI, even if they have an incompatible blood match. Similarly, all mules are a cross between donkeys and horses, and you would think that would be much higher incidence. However, one of the reasons is that we think that there are other factors that may immunomodulate and decrease the risk. So testing for NI, the goal is to detect the presence of maternal antibody that could lyse or agglutinate the red blood cells, because both will ultimately result in their destruction. You can test the mare's blood while she's pregnant, or you can test her colostrum. If you're going to test her colostrum, clearly you have to test it before the foal nurses it, ideally. In general, because the antibodies tend to be stronger hemolysins than agglutinins, many people would suggest that a hemolytic assay is a better test, but actually the JFA, which I'll talk about, is a very effective test, and it's not a hemolysin. The one thing to remember is a Coombs test is not a good way to test for NI, so the commercially available Coombs test will miss a lot of them. So if you're going to test, the ideal test is to use what's called the JFA, or the jaundiced foal agglutination test. This test is nice because it doesn't require complement. To test for hemolytic antibodies, you have to mix either the plasma or the colostrum with the foal's red cells, and then you have to add complement, because if you remember, the hemolysis of the red cell occurs after the antibody binds. It triggers complement to attach, and complement punches a hole in the red cell and lyses it. That's the hemolytic process. Complement is very difficult to work with in a laboratory, and so most labs don't like to do the hemolytic assay because it's very unstable. In the jaundice foal agglutination test, what you're doing is you're taking the mare's colostrum and mixing it with the foal's blood. So you take the colostrum, you do a serial dilution, you add a little bit of foal blood, you mix it, you centrifuge it, and then you pour the liquid out. If the red cells are tightly clumped at the bottom, that suggests that there were agglutinating antibodies in that colostrum. If the red blood cells just pour out at the bottom, just like with the, after the fluid, and they're not strongly clumped down there, that suggests there's no agglutination. So this is a fairly simple test. You can set it up in your own lab. The biggest disadvantage of this test is that you have to either test late in gestation or the colostrum before the foal nurses. And so there's still a need to be there at foaling. Because if you let a foal be born in the middle of the night, it may have already drunk the colostrum long before you actually wake up and test it. This does correlate well with the hemolytic assay. So even though it's an agglutination test, it does appear to pick up hemolytic antibodies. And so the only key is that you do want to get the foal's blood before they nurse, because once they've nursed, whether they're another source of colostrum, the antibody they've absorbed may actually interact with the test and make it hard to interpret. You can also blood type the mare or the stallion. In doing this, you will get a list of all the blood groups and the antigens that animal has, and you will just look for cross-reactivity. So you want to, ideally, you'd like a stallion that's QA and AA negative, because that would mean that there's no risk that the foal is going to get QA or AA positive. If you do decide to breed to a stallion that maybe is AA positive and the mare's AA negative, you can still do a cross match 30 days prior to foaling. So you would collect the mare's serum and the stallion's red blood cells and do a cross match and look to see if there's any evidence of antibody production. If it's equivocal, so there may be some, you can always retest them a little bit later. If it's still equivocal, we strongly recommend that you do the JFA test prior to the foal being allowed to nurse. If you do have to do this and you suspect, let's say you have questionable results and you're concerned that there may be a positive, you do want to try to identify an alternative colostrum source before the foal hits the ground. It's never fun to go running around looking for colostrum when you absolutely need it. It's easier to be prepared and have it. So if you need to give it, you've already got it. So treatment, obviously, prevention is number one. But if you have a foal with NI, the decision to transfuse is really going to be based on multiple factors. First, you want to determine if the foal has clinical signs of hypoxia, because the absolute packed cell volume does not always correlate with the need to transfuse. For me, I use kind of how the foal is behaving. If the foal is so weak and tachycardic and tachypnic that it's struggling to nurse because it has to take a sip and breathe and take a sip, that foal probably needs a transfusion regardless of what its packed cell is. However, if the foal is getting around, nursing well enough that it's gaining weight, even if it's a little bit weak and tachypnic and tachycardic, I may not transfuse that foal. In part because I know that the lifespan of transfused red cells is going to be a week at max. And so I'm only giving him a Band-Aid. And so it's expensive, etc. So if the foal is able to take care of himself, and for me, that means nursing, some activity, and ideally gaining weight, I'm probably not going to transfuse them. So when do you treat? Again, it's combination of the packed cell volume as well as clinical signs. In general, if the blood loss is rapid, so if the anemia progresses rapidly in a short period of time, let's say hours, usually those foals are going to need a transfusion sooner than the foal who maybe has a slow removal of red cells and a gradual anemia. That foal is going to acclimate better to the anemia and maybe not need the transfusion. Another thing you can look at is the venous oxygen. If it's below 40 millimeters of mercury, that suggests that the body is extracting a great deal of oxygen from the blood, and so the foal is really in a negative, and that may indicate that you need to transfuse. Or if the anion gap is increased, typically due to lactate, that suggests that the foal has got so little oxygen that has to do anaerobic metabolism to generate glucose. If you are going to transfuse them, this formula is fairly useful, although it doesn't always accurately predict the need. But essentially what you're going to, the formula includes, so it's the PCV or the hematocrit of the donor minus the hematocrit of the foal. So I apologize. It's the PCV you desire to achieve minus what it is. So if you have a foal with a PCV of 15 and you'd like to get it up to 20, that would be 20 minus 15, it's 5, times the blood volume of the foal, which is about 0.9% of body weight, divided by the PCV of the donor. So the blood volume, like I said, is about 10%, 9 to 10% of its body weight. So for a 50-kilo foal, his blood volume is about 4.5 to 5 liters. So if I say 5 times 5, that's 25 divided by the PCV of the donor. The ideal donor is a gelding, if possible, that's AA and QA positive, really, because they won't have antibody against those blood groups. If you use the mare of the foal, you can, because her red cells would be compatible. But remember, you do not want to use her plasma because her plasma has these antibodies in it. So you have to wash the red blood cells prior to transfusing. So you cannot use them if you don't have an effective way of washing the red blood cells. Prevention, obviously we've already talked about, is testing to make sure that the antibodies don't exist. If they do, come up with an alternative colostrum source, and you have to be there at foaling to muzzle that foal so he can't nurse. How long are you going to not let him nurse? The antibody can persist up to 72 hours. I've always struggled with this question because the gut should actually close in about a day. So realistically, even if there's still antibody in the colostrum at 3 days, the gut should be closed to absorption. However, most people sort of will withhold nursing from the foal for a day or two minimum, and then repeat the JFA and use that as your indicator of when to allow the foal to nurse. Check blood types with parents. Again, QA and AA are the most common antigens. So if the stallion is positive for these and the mare is not, they are at risk. Again, prevention, if there's a history of prior NI foals with this mare, and then immediately post-foaling, if you are worried, perform the JFA. I do have a little bit of information just talking about some common diarrheal disorders in foals that I can talk about if you'd like. I know we're kind of getting beyond the time. I'm going to start with that just because it does work into what we talked about earlier with high-risk foals. So causes of enterocolitis or diarrhea would be probably the most common symptoms. There's multiple ones. In terms of infectious diseases, probably the most common viral is rotavirus. In terms of bacterial, we see a couple of clostridial organisms, C. perfringens and C. difficile, and then salmonella is also a big one. Non-infectious, we can have ischemic injury causing necrosis. We do see nutritional causes, so some milk replacers, particularly if they're not made up appropriately, can cause an osmotic diarrhea. Also volume overload. One thing that will occur with orphan foals is many times with orphans, we teach them to drink out of a bucket. And so we may feed them from a bucket maybe 3 or 4 times a day, as opposed to their normal ingestion. They would nurse every hour, a couple times an hour possibly. What tends to happen with orphans in this situation is when they get their milk, they tend to drink large volumes compared to what the normal foal would drink. And sometimes if they're drinking excessively large volumes, their small intestine cannot digest all the carbohydrates and proteins. And so they end up with protein and carbohydrates in the large intestine, simple starches, etc., that are digested there and cause an osmotic overload and can cause colic and fluid secretion into the gut, and then diarrhea. And so in a foal that in an orphan foal, one of your differentials for diarrhea should be to question the owner about the milk replacer, its how they're mixing it up, and also how much the foal is drinking at times. Sometimes with these types of with orphan foals, simply limiting the amount of milk they are allowed to drink at any one time can resolve a diarrhea. Again, with nutritional diarrheas, you would expect that the foal appears healthy otherwise. It doesn't have a fever, doesn't have petechia, it doesn't have other signs of illness that would be more common with infectious diseases. Foals will sometimes exhibit pica or ingest abnormal things. Sometimes they'll eat sand, so we can see diarrhea associated with that, as well as sometimes with severe parasitism, you'll see diarrhea. I'm not going to spend a lot of time talking about these last ones. I'm going to focus on the infectious causes of diarrhea. So rotavirus, to begin with, that is the most common cause of diarrhea in foals. It typically occurs a couple of weeks to 3 months of age. It's a fairly profound diarrhea. It's usually watery. It's not usually bloody. It doesn't usually have tissue in it, but they can have profound volume loss because it damages the villus enterocytes, which carry the brush border enzymes. So you get both a malabsorption and a maldigestion diarrhea. Clinical signs can be, like I said, diarrhea, profound hypovolemia. They may be colicky due to gas distension and loss of normal GI motility. Because there's loss of the enterocytes and loss of these brush border enzymes, again, they may not be able to digest certain proteins and carbohydrates. And so many times we recommend trying to provide some of these enzymes that are no longer in the GI tract until the GI tract heals. And a simple one is to try to provide lactase, which breaks down lactose, which is the major energy source in the gut, in the milk, until the gut heals. So since they're nursing milk, similar to people with lactose intolerance, will actually provide lactase, and it comes in pill format for people, and just add it to their milk when you feed them to try to help them digest what they're eating, what they're getting. Foals can shed rotavirus for several days. They're a source of infection to others. When you have rotavirus on the farm, it's highly contagious, and so trying to control it can be a nightmare. Mares can shed it asymptomatically as well. Diagnosis, the good news for diagnosis of rotavirus is a fairly easy test. It's an ELISA on the feces, rapid turnaround, so it allows you to quickly determine if you have this problem, so that you can not only institute treatment, but you can institute prevention to try to minimize an outbreak on your farm. So again, this is a viral disease. Treatment is about supportive care, maintaining volume, anti-inflammatories, antidiarrheals. Again, with neonates, even though this is a viral disease, the loss of mucosal barrier would suggest that you should potentially start them on preventative antimicrobials because they're at higher risk of a secondary bacterial infection. So we would consider, as part of our supportive care, a broad spectrum antimicrobial. Lactate, it's about 6,000 units each time you feed it, and try to ideally give it each time you feed the foal, which can be difficult. So we may break that down into slightly less every other feeding, etc. Neostigmine is an anti-acetylcholinesterase. It helps to relieve the colic that you might see due to tympany, and usually this is given at about 1 milligram per foal sub-Q as needed for pain. Prevention is very difficult. It's a very difficult organism to kill. Bleach does not kill it. You need to use phenolic disinfectants and proper hygiene. When you have rotavirus on your farm, it's very important to set up biosecurity protocols, separate the sick foals, have foot baths, have gloves, have people be very conscientious, because the number one spread is fomite by human handlers or by contact between infected animals. Interestingly enough, there is a vaccine that's been developed, although I don't think it's marketed extensively, that you would give pregnant mares that increases antibody production in their colostrum, and has been shown, at least in the areas that have utilized it, to appear to decrease the incidence of this type of outbreak. It's not been published, but there's at least anecdotal evidence from places like central Kentucky that the use of the vaccine has decreased the incidence of these rotavirus outbreaks. Clostridial diarrhea, so I'm sort of lumping them. Clostridium perfringens and C. difficile are the two most common. Perfringens can be a fairly severe pathogen in foals, depending on the subtype. We can see foals that become dramatically sick with bloody diarrhea and die within days with subtypes like A. Subtype C tends to be a little less pathogenic, but from the perspective of treatment, you're going to approach it identically, so I did lump them together. Again, these types of organisms are going to cause fairly significant loss of enterocytes, and so you're going to have significant loss of your mucosal barrier and increased risk of bacteremia. They cause a malabsorptive, maldigestive diarrhea. The diarrhea may be bloody and may have tissue in it as well. And these foals are really sick. They're very colicky, they're very depressed. Clinical signs will include injected mucous membranes, fever, signs of hypovolemia, petechia, a very severely abnormal CBCs. They're often acidotic because they lose bicarb in their diarrhea. They're profoundly hypoglycemic, hypoproteinemic because they lose protein through the gut wall, hypovolemic, and hemoconcentrated. These guys are sick, and so you need to be aggressive in terms of treating them. Risk factors for clostridial diarrheas. This is another farm-associated problem. So with C. perfringens, we will see the pathogen is on the farm, and foals are exposed pre-colostrum and ingest it. The organism sets up house and causes disease. Other factors that can play a role: diet change, antimicrobial therapy that alters the normal flora, although in a newborn there is no normal flora. Stress and concurrent infection have all been shown to play a role in adult species for Clostridial. In the neonate, it's really about the pathogen being in the environment and the animal getting exposed before it gets adequate colostrum. Diagnosis of Clostridial infections. There's no perfect way to diagnose this, and I'll try to explain that. Many microbiologists would argue that the best way to have the strongest index of suspicion is to find large numbers of Clostridial organisms in the feces. So they will actually do fecal smears and look for those organisms, large numbers of gram-positive rods. There are both PCRs for the toxins that these organisms produce, and there's an ELISA that detects a toxin in the feces. The problem with the PCR is that the presence of the DNA for a toxin gene doesn't necessarily mean the toxin is actively turned on. Many Clostridial organisms can have the toxin gene and it's not activated. Probably the best is finding the toxin in the feces using an ELISA. So there are some ELISAs that look for specific toxins from Clostridia. And I would argue that if this is probably your number one test because it's going to be the most easily accessible and rapid test. Finding the large numbers of organisms in the feces is also very strongly indicative, but is going to take some time and probably be less useful. Treatment for these guys is going to be aggressive fluid therapy and colloids because they're often hypoproteinemic, so plasma. Typically in these cases, we would put these horses either on high-dose penicillin or oral metronidazole at a dose of 10 to 15 milligrams every 6 to 8 hours. If they can't tolerate it orally, there is an IV formulation, but it is quite a bit more expensive. Again, neostigmine can be used for colic. In outbreaks, some people have used the cattle antiserums that are available and given them orally. There's not a lot of data to suggest that that works, but it has some logic behind it. Other people have suggested giving the hyperimmune plasma orally, again, with the idea that in both of these, you're giving antibody against the pathogen and maybe decreasing its effect by having the antibody bind and then the immune system take the organism out of the system. The other big and severe cause of diarrhea and is salmonellosis. Again, this is a fecal oral infection, so again, having salmonella in the environment. Young foals are more susceptible to getting sick with salmonella because they don't have a normal GI flora. Interestingly enough, mares that are asymptomatic carriers will actually increase their shedding as they get close to foaling, making them a higher risk for the neonate. Salmonella, similar to Clostridia, enters the enteral site and enters the lamina propria and causes a septicemia. It denudes the mucosal barrier as well. With Salmonella, we do actually see, it's not uncommon to see it affect other organ systems, the bone in particular. I've had multiple neonates present with osteomyelitis that turns out to be associated with salmonellosis. Prevention of salmonellosis is, we know in other adults and other species that protective barriers, so gastric acidity, normal flora, peristalsis, and then enzymes and intestinal mucus. Because the foal has the immature gut, does not have a complete normal flora, and if colostrum hasn't been ingested, its gut is open, they're at a much higher risk for getting sick from salmonella. Treatment is similar, really, to Clostridia. Again, aggressive fluid and colloid support because they often have significant fluid losses, broad spectrum antimicrobials. Anti-inflammatories are recommended, actually should be for Clostridial too, because they often have inflammation. The prognosis, depending on the pathogenicity, tends to be guarded for Salmonella, with Clostridium as well, guarded to poor depending on the virulence of the Clostridium. In terms of kind of overview for bacterial diarrheas or diarrheas in general, farm prevention, again, if you suspect you have a pathogen like this, you've lost a foal or you've cultured a foal and you have Clostridia or Salmonella, hygiene becomes really critical. You need to think about the fact that these foals are ingesting this pathogen before they have any kind of colostrum in their system that may help coat and prevent the absorption of this pathogen. And so when you think about when a foal is born, they're born, typically the mare defecates in late stage gestation, and so they may actually be born into a pile of manure. Even if they're not, once they get up, they often, while they're udder seeking, will walk around. They may lick the walls, they may suck on their mom's stifle, nurse around her belly, etc. And there may be fecal contamination in those areas. There typically is. And so that's an opportunity for them to ingest that organism before they've actually ingested colostrum. And so your goal should be to prevent this from happening. So hygiene, cleaning the udder, cleaning the perineal area, disinfecting the stall and removing feces. Remember, if you have wood walls in your stalls or a dirt floor, you cannot disinfect organic material like that. And so sometimes if that's the situation, you're going to be smarter to have that mare foal outside in a pasture. Pastures are a lot cleaner compared to stalls. You can potentially foal her in a relatively empty pasture and allow her to foal in a relatively clean environment. The other thing to do is to be there at the foaling, make sure the udder's clean, the perineal region's clean, and simply prevent the foal from going and exploring the environment until it's gotten colostrum. To be honest, in these types of situations with a farm outbreak, my recommendations would be to have the farm people there when the foal is born, and to have, when the foal is born, to have the veterinarian come out, pass a stomach tube, and tube feed the foal colostrum before they allow it to do anything else. That way you're ensuring that they've got those protective antibodies in their body before they start to get exposed to the environment. Bottom line, treatment of foal diarrhea, you don't necessarily have to know what it is to know how to treat it, really. IV fluids and plasma are going to be the mainstays of your treatment. Systemic antimicrobials, even if it's not a bacterial infection, you're probably going to want to cover with antimicrobials because of the risk of secondary sepsis. If you think it's clostridial, oral antimicrobials like metronidazole probably have some better benefit in the GI tract. Gastroprotectants, things that may coat the GI tract and minimize the diarrhea, so Pepto-Bismol, omeprazole, which is a proton pump inhibitor, and trying to decrease some of the secondary side effects, so lactase to help digest the nutrition that they are getting, and then yogurt or other probiotics to try to establish a normal flora to try to help the GI tract heal. In terms of the bottom line diagnosis of foal diarrheas, we would routinely, first of all, do the rotavirus test, do fecal cultures in the mare for salmonella and the foal, minimum of 3 to 5, and do the toxin assays for the C. difficile and perfringens toxins. If the foal is bright alert and responsive and not febrile and doesn't look sick, remember to think about other non-infectious disease causes of diarrhea, like nutritional or sand ingestion or parasites. Hygiene is really important. Foot baths, minimize traffic, protective clothing, PPE, gloves, clean the stalls. If you can't disinfect them, foal the mares outside. And like I said, when the foal is born, it's not a bad idea right prior to foaling is to literally wash down her perineum, give the mare a bath, wash down her udder, wash down her perineum, wrap her tail, and then work to make sure that that foal gets colostrum before he starts to wander around the environment and potentially ingest these contaminants. If you have a farm outbreak with one of these diseases, I put this about consider early antimicrobial therapy. Prophylactic antimicrobials are probably not going to be as beneficial as the other things I've mentioned, but careful, frequent monitoring of the foal and instituting early antimicrobials if you suspect they're getting sick is going to be probably critical as well. I think that's all I have about disease today. I've kind of gone over. So I think I will end here and take any questions.
Can you thank you. Indeed, that is exhaustive going for about 2 hours, 10 minutes. Thank you, Dr. And in fact, we should learn from you to run for this lecture without getting tired. So there are many questions. I'll read out the questions, but most of them are actually answered in the lecture. Fluid for neonatals, cholesterol substitutes in case of death of dam, then common diarrhea, joint infection, foals, pneumonia, oxygen therapy, salmonellosis, neonatal erythrolysis, like that. Almost all the topics, the questions they are put in the chat section is already answered in the lecture. So maybe only one. If the foal, there is a delay in passage of meconium, what is the drug and the dose to be used?
Okay. I actually have a couple slides I can talk to you about. I'll pull those up and run through them because I have that was one thing I wanted to talk about. One other thing I wanted to mention that I did talk about, but just to kind of expand on it, there's many studies that people do where they have they deprive foals of colostrum so that they can do pathogen studies. And interestingly enough, those foals, if they don't get colostrum, tend to have a lot of problems, as you'd imagine. They tend to be sicker. But interestingly enough, one of my mentors spent some time in Japan where they were doing a colostrum-deprived study on foals. And what they were doing with those foals, and at that time, if we were doing colostrum-deprived foal studies, they were in isolation with, trying to minimize exposure to pathogens. And in this study in Japan, they had these foals in a barn. It wasn't an isolation barn. And when they were foaled, they took them out from their mare and they simply fed them milk from the grocery store. And then they put them on an antibiotic after that. And those foals did great. They did not get sick. And I think the take-home message was, by feeding them, they kind of hastened the closure of the gut and they decreased that risk of exposure. So sometimes you don't have colostrum, you don't have cow colostrum, you don't have the money to give them plasma. That you can still save that foal by simply feeding them. And then again, if you're worried, putting them on an antimicrobial until you feel like they're kind of stable. So I wanted to at least bring that up because we get very focused on colostrum. And while it is a great thing to get into them, there are times where you can't. And you don't want to necessarily say, you can still have a completely healthy foal that can grow and do well if you just kind of institute a few other plans. So let me get to my, so. Sorry. Okay. Okay, let me share this. Okay, can you see my slide?
Yeah. Yes.
Okay. So I had a case, but I'm going to just talk about meconium impactions. So meconium impactions are a very common cause of colic in neonates. Remember that, interestingly enough, there's some data to suggest that when a foal has a very bad meconium impaction, they actually have mentation abnormalities. So they can appear like this classic dummy foal. And the idea is that there may be some absorption of compounds within the colostrum or within the meconium that actually alters brain function. And interestingly enough, sometimes just resolving a meconium impaction will significantly improve the mentation and the behavior of a foal. So it's a really good segue. I'm glad you guys asked the question because treating meconium impactions can actually be beneficial in other ways as well. So there's lots of things you can do to diagnose them, but I think what we're going to talk about is probably, oops, the wrong way. So there's two ways you can do this. You can, and probably the simplest is to do a warm water enema, which is basically you take maybe a half a liter of warm water. It does not have to have any kind of detergents in it. So sometimes we get stuck that we have to put a detergent in. The problem with the detergent is that it is also irritating. And so it'll cause inflammation and irritation. And if you do multiple, let's say, soapy water enemas, like dish detergent, eventually the foal's small colon is so irritated that it strains and strains and strains. However, there are times where just a simple water or soapy enema won't resolve it. And the next step should be what's called an acetylcysteine enema, which it's called an acetylcysteine retention enema. So acetylcysteine is a drug that is used in people with cystic fibrosis. And if you remember, they have abnormal chloride channels and they develop a lot of mucus and exudate in their airways that they can't clear. And acetylcysteine breaks down the bonds in this mucus and actually breaks it up so that they can clear it better. And so people with cystic fibrosis will actually have acetylcysteine inhalers that they will inhale. It breaks down disulfide bonds, which breaks it up and helps lubricate and in the meconium as well. And what was shown several years ago is that if you take powdered acetylcysteine and mix it up into a solution, you can actually help break down meconium impactions. So the recipe is you take 8 grams of acetylcysteine, and this is, if you buy the powder form, it's very cheap, so you can just have it on your shelf. You mix it up in 200 mils of water. You want to add about 20 grams of bicarb to that, so simple sodium bicarb can be added to it. And then you would take a Foley catheter, The size doesn't really matter as long as it's small enough to fit in the rectum. But it does have to have a big balloon, a 30 mil balloon, because your goal is going to be to lubricate it, slide it into the rectum, and then distend the balloon so that when you put this acetylcysteine enema in, it's a retention enema. So once you've got the balloon in, you're going to slowly infuse this 200 mils plus or minus how much they tolerate into the rectum. And then you're going to want to elevate their hind end. Sorry, I'm kind of jumping around here. Elevate their hind end and sedate them so that they lay quietly for you. So we typically use about 0.1 mg of Valium and 0.1 mg of butorphanol per kilogram. That's going to sedate the foal. You can put either a mat or something under their hind end, so now their hind end is elevated, and leave that retention enema, so clamp the tube and leave it in there for 20 minutes minimum if they'll tolerate it. I usually leave it in until they want to wake up, and then I unclamp it, deflate the balloon, and let them get up. And because that acetylcysteine breaks up the meconium, it's very effective at resolving a meconium impaction. Even a high meconium impaction, if you elevate their hind end and infuse it and let it sit there for a long time, it will break it down. It's very effective. As far as trying to control the pain of a meconium impaction, we would typically, in our hospital, use butorphanol or turbogesic as a pain med. In neonates, we don't tend to use a lot of xylazine because they have profound hypotension and bradycardia with it. So you can give IV fluids. I did put this in for the treatment of this foal that came into our hospital. But in all honesty, out in the field, in a healthy foal that just had a meconium impaction, I would simply perform the acetylcysteine enema. I don't know if that helps.
Yeah. Thank you. Yeah. So we have enjoyed your lecture. In fact, it was very informative, providing important tips, especially on position of foals during recumbency, cholesterol substitutes, more emphasis on sepsis, diarrhea, and including use of yogurt. Thank you very much for readily accepting for the presentation. In fact, this is your second presentation, and we are very indebted for that. I also thank you for identifying or introducing and getting acquainted with Dr. Angel for the another class of webinar. Thank you once again. And we all thank you from the bottom of the heart for a wonderful lecture running for more than 2 hours, 10 minutes. Thank you. And now we call upon Dr. Arunaman, Assistant Professor of Clinics, for vote of thanks.
Thank you, sir. Yeah, good evening, everyone. First of all, we thank our Honorable Vice Chancellor, Tamil Nadu Veterinary and Animal Sciences University for giving permission for conducting the webinar and consent to present inaugural address in spite of the busy schedule. Thank you, sir. We thank the Director of Clinics, TANUVAS, and Chairman and Convener of the webinar for his support, coordination, and encouraging the faculties of organizing committee for the smooth conduct of the webinar and for his crisp note on the webinar. Thank you, sir. We thank the speaker, Dr. Elizabeth CARR, Associate Chair, Large Animal Clinical Sciences of Michigan State University, for the very wonderful talk on critical care and medical management of diseases in foals, which really benefited the staff and the practitioners. We thank Mr. Karunanidhi, Vice President, and Dr. Santosh Shinde, AGM, Alembic Pharma, for the technology support through MS team for the smooth conduct of the webinar. We thank the deans and faculties of all the constituent colleges of TANUVAS for their continued support and encouragement for the conduct of the webinar. On behalf of organizing committee, we thank Professor and heads of departments of Animal Husbandry Statistics and Animal Husbandry Extension for deputing the faculties and staff for the webinar. We extend our thanks to Dr. P. Tirunavakarasu, Dr. N. Vimal Rajkumar, Assistant Professors, for helping us in successful conduct of the webinar. We also thank every member of the organizing committee, including Dr. Sendil Kumar, Dr. Shankar, Dr. Arul Kumar, and Dr. Vikrama Chakravarti for their coordinated work. We thank the participants who made this webinar a grand successful one. Once again, we thank one and all who are involved in successful conduct of the webinar. Thank you.
Thank you very much. Dr. Napoleon, sir, you have any few words to say about? I request Napoleon.
Yeah, it was a wonderful lecture by Dr. Elizabeth Carr. Of course, again, we should not say that it is more than 2 hours. It was completely the management with respect to the raising a very healthy foal. It was very, very nice, madam. Okay, really, it was very informative and thought-provoking. I hope all the practitioners, especially in equine stud farm, would have been benefited, and it was really an eye-opener. So once again, thanks a lot on behalf of our university, our Directorate of Clinics, and the organizing team. Thank you, madam. Thank you.
Thank you, Dr. Elizabeth Carr. We are thankful, and you can sign off.